Hey guys, it's Dr. Rad. It is so good to see everyone. Thank you for joining me. This is a really big week. We've been at this only for like a month, and we are celebrating 1,000 fans, which is awesome. So we're really excited about that. This has been something I've wanted to do for a long time. I'm finally doing it. I think it's awesome. I think it's educational. I enjoy it. I love the fact that it's interactive. That's so cool. I can get these questions. I can feed them back. The fact that you guys are throwing questions in ahead of time is way cool, because then I can actually put some real thought into it instead of on the fly. But this is exciting. It's a lot of fun, and I'm enjoying it. I'm enjoying it a lot, and hopefully you are too. Speaking of which, if you find this educational and you do like it, please feel free to share it. I know that's a little sales pitch, but it also is, it's the reason I'm doing this is for mostly education. Get it out there. I can only reach one patient at a time during a 15-30 minute interview. This can be shared. This is fun. These are the questions, and I want you guys to ask them that you could ask any surgeon or any doctor. So bring them on, and then we can share this with everybody. So it's a lot of fun, and I think that's the appropriate platform for it is this, and that's the way I want to do it. So thank you for following Dr. Rad, Instagram, Facebook, all those great things, and I just appreciate it. I appreciate this opportunity. One other big shout out, because this is actually really cool. The Whole Family Health Center in Vero Beach is a nonprofit health center. They had this really cool competition, and it's a big deal, and you guys know I'm a huge fan of the mask. So they had this competition where you just submitted a picture of yourself with your mask on, and we won! So hey, how about them apples? I got this cool cup and some trinkets and a Starbucks gift card, because they know I like my coffee. Coffee is like the nectar of the gods. It's dangerous but necessary. Anyway, let's get started. So today we're talking about abdominal pain. I know that is really vague, but that's why I think it's important. When someone comes to my office and they're talking about their belly pain, right? Sometimes I get a referral literally from a primary care and it just says belly pain. And that doesn't mean much, but sometimes it is that vague. And I'm sure many of you have been to a doctor or talked to your friends and they'll be like, I've got this pain and it just won't go away. It's been a day, it's been 2, it's been a month, it's been 6 months. And it's not enough that you want to make a big deal out of it, or maybe it is. But you just don't have a good answer, or you go to the doctor and they don't have a good answer, or you're not sure if it's like, is this a big deal? Is this something I should be worried about? So here you go. This is the opportunity to talk about it. What I'm going to do is try to separate this out into a couple of platforms. One, we're going to talk about acute versus chronic. So let's talk about those words, because they can be a little bit difficult. Acute means this just happened. It's an acute onset. This just started. So from a standpoint of acute pains, you can have gallbladder attacks and appendicitis and some kind of infections. You can have a bicycle accident and take a handlebar into the belly and perforate your bowel. There can be a million reasons why you have an acute problem. Acute situations can be much more serious and are typically more surgical. So we'll put that to the side. Now let's talk about chronic. One of the questions I actually had this week was, I said something about pain being real, or is it legitimate or whatnot. What I meant is chronic pain. When I say real, meaning is it a real surgical problem? All pain is real. Whether you're experiencing it constantly all day long, or if it's just happening at that moment, or if it comes and goes. It's real. What I mean by surgical pain is your pain something that can be treated surgically? Or is this something you need to go see a gastroenterologist for? Very important doctors. Is this quote-unquote IBS, irritable bowel syndrome? Is this just a genetic thing with constipation, diarrhea issues? These are more chronic issues. They come and go. They are worsened by certain foods. These kind of chronic conditions. For instance, what many people deal with is like reflux. Reflux, everybody's like, oh, heartburn? Well, yeah, heartburn. But if your reflux is bad enough, you can have esophageal spasm, to the point where there's actually a medical condition known as nutcracker esophagus, and it's where your esophagus really kinks off and it can literally feel like you're having a heart attack. But you wouldn't know it. You'd think you're having a heart attack and you rush off to the emergency room and they do an EKG and you're just fine. And then they tell you, oh, it's just reflux. And you go, huh? Reflux? Absolutely. And it can absolutely present like a heart attack. And it's scary. It's very scary for everyone. So let's kick it off. So I wanted to make sure that those are the two areas that we kind of attack, acute and chronic. And now that you know those definitions, let's move over to my whiteboard. As my good friend Tim would say, whiteboards are awesome, because they are. He homeschools his kids, and they're really cool kids. And I bought this whiteboard because whiteboards are awesome. And in theory, you can erase it when you make a mistake. So it's great. I'm going to need something to wipe the board off with maybe. So let's grab that. All right, so let's talk about pain. I'm going to sit up here. Let's talk about the belly. All right, so first off, I am not an artist. Let's get that straight. Don't make fun of my artistic capabilities, even though I would not blame you. All right, so if we talk about the belly, there's your belly button. All right, so chest, groin, everything in between is the belly. All right, now let's talk about location of pain. Location of pain, thank you. Location of pain is important, right? Because if you're going to go to the doctor and you want to describe your pain, you need to describe your pain with a couple of very specific things. One, does it come on quickly or does it come on nice and slow? Is it always there or does it come on hard and within a couple hours it's completely gone? Other things, how long have you had it? Has this been going on for years or is this just something that just happened to me last night? Some other things, dull, achy, kind of like cramping pain, or is this sharp, like literally somebody stabbing you with a knife? And one of the only last things that you really want to talk about is genetics. And I only say that because if Crohn's, ulcerative colitis, even constipation, diarrhea, these things can run in the family. These are very important for your doctors to know about because it takes a lot of the guessing work out. So just think about that before you go to your doctor, and those are important things. I want you should write those down so that you go in and there's no guessing. You just tell them, look, here's the deal. Boom, 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 boom. Doctors love that. Surgeons really love that. It just takes the guesswork out. Okay, now let's talk about location, because location's key. Things live in your abdomen in certain areas. They don't typically drift very much, so you can kind of separate these things out. So let's separate our abdomen into 4 quadrants. All right, let's call them 1, 2, 3, 4. All right, now, hopefully you can see this red. I'm hoping it shows up. If not, I'll try to mess with it later and kind of get you hooked up. Okay, now, number 1, let's talk about the right upper quadrant, because the number 1 general surgery done in this country is, if anybody can guess this, you win. If you don't win anything, you're just really smart. All right, number 1, gallbladder. All right, right upper quadrant pain. So let's talk about this. Let's separate this out here. And if my board falls over, you can absolutely all make fun of me. All right, gallbladder. All right, gallbladder lives in the right upper quadrant. It's just under your rib cage in the right upper quadrant. I'm going to warn you though, the gallbladder's nickname is the Great Masquerader. And there are many, many reasons for that. It can show up as what we think are 1,000 different things. Number 1, it can present like reflux. Number 2, it can present like heartburn, belching. It can give you diarrhea. It can literally make you constipated. It can do almost everything. Now, there's this fancy word. You cannot use it on Scrabble because it has way too many letters, but it's called pathognomonic. Pathognomonic literally means this is exactly how it's described in the textbook. That would be right upper quadrant pain. It's pain that goes sometimes through to your back by your scapula, maybe your shoulder. It happens absolutely after a fatty or greasy meal. Why? Well, bile from the gallbladder is actually ejected from your gallbladder into your small bowel and helps you digest fat and greasy meals. So, if you think about it, if your gallbladder's not working right, well, you're not digesting fatty, greasy meals and you can have diarrhea. You're not digesting those things, you can have heartburn, reflux, these kind of things. And then, of course, if your gallbladder's trying to squeeze down, but some gallstones are in the way, or the gallstones are hurting you, well, that's the right upper quadrant pain. This can come in all kinds of pain forms. I'm going to tell you right now, the worst ones will drop you to your knees. You will absolutely be screaming out in pain, and it hurts like nobody's business. And then all of a sudden, it's gone. And of course, usually that happens right after you get to the emergency room and they give you some morphine and it's just gone. And you feel like a doofus because you went to the emergency room and got seen, and all of a sudden, it's important. In the emergency room, they'll probably do an ultrasound, show you got stones, they'll do some labs and things like that. You'll have some elevated LFTs typically, things like that. But right upper quadrant, those kind of symptoms, you got to be thinking gallbladder. The problem is gallbladders can be chronic, right? It's this vague right upper quadrant or epigastric, meaning right under this bone right there called your xiphoid, that point right in the middle of your chest at the very bottom. Those two areas are gallbladder. If you have that and it's vague, most of the time within a couple hours after I eat, it just doesn't go away. It's just kind of, you know, and then it'll go away. But after I eat that next pizza or hamburger, it comes back again. That's still your gallbladder. Typically, you can do some special tests, a HIDA scan, other things like that, and you get it figured out. But that's where I want you to be thinking with that. What else lives in the right upper quadrant? Now, that's our big ones, but what else lives in the right upper quadrant? Your duodenum. Your duodenum is right after your stomach. You eat, goes down the goose, the esophagus, into your stomach, which is shaped like a kidney bean, and then comes right over here, right past the muscle that separates your stomach from your small bowel. That area is prone to ulcers. It's called your duodenum, so it's duodenal or gastric ulcers. They're again at that epigastrum or that right upper quadrant. That can absolutely be the pain. Let's think of a couple things that would tip you off to that. So if you are working in an emergency room and somebody says, hey, I have this horrible right upper quadrant pain. It just came on, okay? I've been taking ibuprofen or NSAIDs, things called NSAIDs, ibuprofen, Aleve, things like that, for like 2 weeks in a row around the clock. That's your story. Those can give you ulcers, and those ulcers can get big and nasty. They can hurt. Believe it or not, food usually makes it feel better because it kind of coats your stomach, and they can absolutely perforate, and that can be a really big deal. In fact, back in the 70s, the #1 surgery that general surgeons did was removing part of your stomach for big ulcers that perforated. Then we came out with PPIs, right? Protonics, Nexiums, omeprazole, things like that. Changed the game, right? So those are few and far between nowadays. Stress ulcers are the same thing, but typically stress is the little baby ulcers, but if not taken care of and you're taking NSAIDs on top of that, it can absolutely give you the same pain. So you got to think about that in the right upper quadrant. So we'll say ulcers. All right, what else you got? Right upper quadrant. You have some colon that lives up there. Some of your liver lives up there. The right lobe of your liver lives up there. But there's not much else up there that's really going to give you that pain. Those are the two big ones. All right, so let's move over to number 2, the left upper quadrant. Left upper quadrant, really not much there that's going to give you pain. You have the top of your colon that goes across there, but the only guy that lives up there is, if anybody wants to guess, starts with an S. Spleen, that's right. Spleen. What in God's name does the spleen do? So the spleen is interesting. When you're a kid, it helps you out with your immune system. It helps filter out, red blood cells and things of that nature. What it does for you as you become an adult is it filters out cells that are dying, like red cells and stuff like that have kind of gotten to the end of their lifespan, and the spleen filters it out, degrades it, sends the byproducts back to your body to make some new ones. So it has a purpose. It is unnecessary, meaning if you got into a car accident and you fractured your spleen, if they took it out, are you going to be okay? Absolutely. The spleen lives in that left upper quadrant. It's under your rib cage though. But if you get one particular virus, typically it's called the kissing disease because you get it from kissing. Teenagers get this a lot. They feel fatigued for 6 months to a year. They get left upper quadrant pain because their spleen gets huge. We call that splenomegaly. It is called mono. And they call it the kissing disease also because your tonsils get so big, when you look in their throat, they actually look like they're kissing. That's why they call it the kissing disease. That, and you get it from kissing. So, the spleen lives up there. If you have mono, it can actually make your spleen really, really big, and you get that left upper quadrant pain or left abdominal pain. So that's one. I will tell you also, another guy that does happen in the left upper quadrant is constipation. And the reason why is the rectum is down low, the sigmoid's low, but if you're backed up, the pressure head is back up that left colon and up to the left upper quadrant and left lower quadrants. Constipation's a big one. You've got to think about that. All right? So there's not much else that lives in the left upper quadrant, so we'll move on from there. Number 3, right lower quadrant. All right. Everybody should know that your appendix, we're going to say appy for short, your appendix lives there. That's a big one. So let's talk about the pathognomonic terms for your appy. Perfect story. You got two, again, this is not everybody, 14% of the population is going to get appendicitis over their lifetime. But let's talk about it. You have, it's a bimodal response. It's typically 20s to 30s, and believe it or not, over 60. Like it's a wide range, 60 to 80, maybe 70 to 80 would be closer. So there's actually two subsets of people who get it a lot. Now, yes, there are children who get appendicitis, but it's actually rare. In kids, it's actually just lymph nodes, or the lymphatics actually get swollen and it blocks off their appendix and it gets big like a balloon. It can burst. But again, it's rare. It's typically that bimodal response, the younger age, you know, just out of college kind of kids, and or 17, 18, 19, starting that age to up to 30, and then that 60 to 80 range. All right. Right lower quadrant pain, if you take your hip bone, the top of your hip bone, as high as you can get on your hip bone, and you draw a line to your belly button, then you go 2/3 of the way from your hip to your belly button, boom. That is called McBurney's point. All right, that is, so if you have a surgeon coming into this emergency room and he's like, wow, I think we got appendicitis. The surgeon goes, okay, he walks in. The first thing I say is, you got one finger. Where's your pain? One finger, one spot. 95% of the time they go right there. And it's exactly at McBurney's point. So, I wish there was a Radke's point, but there's no such thing. I'm working on that though. Now, there is a wrestling move called the Radke roll, by the way. That was invented by my father. Long story short. McBurney's point, right lower quadrant pain. But it doesn't start there. That's the key. So now I'm going to tell you a personal story where I screwed up big. Ready? My wife, sorry Jenna, I love you. My wife calls me, I'm at work one day, and I'm in the clinic, and she says, you know, I just don't feel good. I said, what's wrong? She goes, I got the worst reflux. I said, you should take some Tums, honey. I got to go. I love you. I'm busy. I got work. She goes, okay. She calls me back an hour later. Man, this reflux is just unrelenting. It's killing me. I said, okay, baby, take some Pepto-Bismol. She goes, we don't have any. I said, well, take something. I love you. You're going to be fine. It's just reflux. You know, I don't know, whatever. She calls back a couple hours later. This is not. My wife doesn't do this. She says, man, I've got, just, my belly doesn't feel good. I'm nauseated. I just don't feel good. I said, are you pregnant? And she started laughing. She goes, no. I said, all right. I said, honey, I'll pick up something on the way home. I'll be there in a couple hours. I love you. Gotta go. So I'm driving home. I stop at the store, and like it was kind of supposed to be a joke. I picked up the biggest bottle of Tums, this massive bottle of Pepto-Bismol. I picked up all this stuff, and I walk in the house, and she's not here. I'm like, what's up with that? And I said, kids, is mommy all right? Oh, she's upstairs, Dad. She's in the bed. So I walk upstairs, and I go, honey, it's like 6:30. What are you doing in bed? She goes, I just don't feel good. And she looks horrible. I said, what's going on? She goes, well, my belly pain started kind of in the middle by my belly button. But now it's right over here on my side, on my right lower quadrant. I just looked at her and said, you have appendicitis. She goes, no. I come over, I push on her belly, McBurney's point. She looks at me like she wants to punch me in the face. We got up, walked outside. By the time we got to the car, she throws up in the driveway. Get her in the car, take her, CT scan. She's got appendicitis. Her appendix came out that night. But even I missed it. You've got to remember, Belly pain starts typically by your belly button, and then what we call localizes, moves and migrates to the right lower quadrant over time. Do not sit on this. Appendicitis is easy peasy, lemon squeezy. If you come in early, you go in laparoscopically, a couple baby holes, staple it off, remove it, you're done. You go home that night or the very next morning, and it's just a bad day, and you move on. If you sit, and you sit, and you sit, men, we're really bad at that, don't do that, then you can ultimately end up having some big trouble, perforate your appendix, and that's a much bigger surgery, a much bigger problem. So there's my advice on that. What else lives in the right lower quadrant? Again, constipation. You can actually have diverticulitis, which we're going to talk about in a second, in the left lower quadrant. If your sigmoid colon that usually has diverticulitis is so big that it actually wraps over here, but again, that's rare. There's not much else cooking in the right lower quadrant. Let's move on. Left lower quadrant, and then we're done with that, and I'll make a very short comment on girl parts, because that is really vague and difficult to diagnose. We'll just kind of hit on that. But the left lower quadrant, so the big one from the left lower quadrant is diverticular disease. Divertics. And we'll just leave it at that. What in holy graces is diverticular disease? Okay, diverticular disease is our colon, your large bowel, not far from the rectum, comes over and starts sliding up that left lower quadrant. If you're going to have a pressure head, right, so pressure builds up because stool does back up, the pressure head is in the sigmoid colon, right there at that left, right by your hip bone on the left side. You have these little things, they're little outpouchings. They're little outpouchings of your colon. They come under pressure. I will tell you right now, the huge majority are genetic. I will tell you that it is ultimately rare, but can happen a whole bunch. So I see a ton of it all the time. What I mean by rare, 50% of people over the age of 50 have diverticulosis. That means those little outpouchings of their colon, little herniations of their colon. So lots of people got it. Only about 20% of that 50% will ever have a bout of diverticulitis. That itis is inflammation or infection. Only 10% of the 20% of the 50% will actually ever need an operation for it. So I don't want you to think it's too exciting, but if you got left lower quadrant pain, it is certainly not rare. This can be your problem. What happens? Well, one of those ticks or outpouchings can get stool impacted in it or food impacted in it, and it can actually cause a small rupture. And I mean a hole the size, not even of a piece of corn, sometimes the head of a pin. But you can imagine that if any stool leaks out of that hole, it causes mayhem in your abdomen. Your belly doesn't like it at all. It is as if you had perforated appendicitis. It is that bad. But it's left lower quadrant pain. If it's inflamed, if it's angry, your bowels can shut down. They can lock up. You can't go to the bathroom. Or just the opposite. They're inflamed and angry, so you have severe diarrhea. Again, I know it's two signs, but if you mix diarrhea or constipation with left lower quadrant pain, and you're normally not constipated, this is something you got to think of. Typically, I wouldn't say you need to worry about this till you're at least in your 40s or even 30s if you know you have a genetic propensity towards this. Otherwise, it's 50 and older typically. Again, left lower quadrant. You'll get typically, like appendicitis, you'll get fevers, chills, and abdominal pain that will not go away. All right, the last one, which is not a quadrant, but we're going to talk about it, is the pelvis. So that is everything from the belly button and hip bones down. All right, those can be interesting. Let's talk about boys first. Boys don't have ovaries, right? But we can get inguinal hernias. There are two places where everybody, actually, let's talk about 5 places where everybody can get hernias. But boys are certainly more prominent to get these. Boys' testicles start right where girls' ovaries are. Before you're born, your testicles are in your abdomen. But during that birth process, or slightly before, or even a little bit after, your testicles descend through a canal and into your scrotum. but they leave a natural weakness behind. The door is supposed to close behind that, but sometimes it doesn't. Sometimes there's just a natural weakness there. And then as our lives go on, we lift heavy things and do dumb stuff, and we think we're big bad guys and lifting weights, and we can absolutely bust out a hernia in that area. So that's something. If you see a bulge or you have pain at a pinpoint area, take it from a guy who's had both of those repaired. Don't put it off. I will tell you, there's one thing I would remember about hernias. I love primary care physicians, but sometimes they feel it's their job to save you from surgery. And I think that that's very important. In fact, I'm one of the few surgeons I know who will absolutely try to keep his patients out of the operating room. Hernias are, I feel, just the opposite about them. And the only reason I can say that is because I feel if you knew how easy it was to repair a hernia when it's small, it's so easy. If you wait till that hernia is huge, and I did that, trust me. And as a patient, I wish I would have gotten that thing fixed much earlier in the process when it was teeny tiny. I had my left inguinal hernia repaired. It had to be open because it was so big. It took me 6 to 8 weeks to recover. I never got my flexibility back again, and it hurt like the dickens. I had nerve pain, I had mesh pain. It was very difficult. I had my right inguinal hernia repaired laparoscopically. It was small. I was up walking my dog that night, and had it on a Friday. I was back to work on a Monday. Huge difference. I want to say that. If you have a belly button hernia, if you have any other kind of hernias, get it done when it's small. That's just my best advice as a surgeon. I know it's miserable. How can you justify taking time off work? How can you justify these things? But if it's small, it's one and done. Your recurrence rate is infinitely lower. It's typically 1 to 3% versus if it's big and it's complicated, your recurrence rate can be 30 to 60% or higher. So do yourself a favor. Get them repaired when they're small. Belly button hernias are number 2. They are very common. It's a bulging in your belly button. You can actually push on your belly button, and if you feel it, we call it a defect. It's a little hole that you can actually sometimes get your finger in, or you can reduce it, like meaning push some of this contents that are in the hernia back into your belly. You got a hernia. Get it fixed if it's small. Get it fixed if it's big, but don't wait till it's big. Ovaries. Ovaries are complicated. And you know what? Maybe one of these talks I'm going to bring one of my GYN friends and they'll do it with me. Ovaries are difficult. They typically come in pain that is with your typical menstruation period or when you're ovulating. If you know you're ovulating and you're timing these things and you think, okay, I'm going back 14 days from my last period, yeah, that makes sense. Then it can typically be an ovarian cyst. You get cysts, we get follicles, they get big. It's right lower quadrant pain, left lower quadrant pain, these vague abdominal cramping. Women with menstruation, that's another difficult thing because a lot of times people will tell you, oh, it's just your uterus. Oh, this horrible cramping is just how, that's what you got to live with. Many times that is genetic. I will make a plea to you. Please go to your gynecologist so that you can get this worked out. We have great pills. We have low dose birth controls. We have uterine ablations. We have laparoscopic through teeny tiny holes to take care of these cysts if need be. There's so many great things we have these days that you don't have to live with that. So please go visit your gynecologist or your primary care if they do a lot of GYN. That's super duper important. Okay, so that's our quadrants and that's our pelvis. Only a couple of the little things to mention are if you've had surgery before on your abdomen, they've made an incision, those areas are weaker than they ever were before. It's an injury. It is what it is. If you heal from a surgery, say a big incision on your abdomen, the best you're ever going to be is about 86% of the strength that you used to be. Problem. Well, you can get a hernia at that area. So because it's weaker, the abdominal wall is weaker, you can absolutely bust that out, especially if you're, one of those people who works in, lifting patients like nurses do, lifting weights. You're trying to get back in shape and you feel something pop, you got to be thinking hernia. The problem with hernias are, okay, you can reduce them, no problem. The issue becomes if something like your bowel gets through that hernia and gets strangled off, that's an emergency. You could lose your bowel. You can absolutely have your bowel become ischemic. You lose your blood flow. You got to take it out, close the hernia, and it's a much bigger complication. So don't do it that way. All right, I think I'm done talking about quadrants. I'm going to move back to the middle of the couch, and I want to answer some questions because there's actually some really good ones here, and I like these. This says, Teresa, Dr.Rad, I had bowel surgery in January, and I am starting to have the same symptoms I had prior to surgery. What should I do? Teresa, that's a great question. Here's the problem. I don't know exactly what surgery you had, but if it's the same symptoms, you got to ask yourself, one, did we get the diagnosis right? So if a surgeon did, let's say, a lysis of adhesions, but your bowel pain is starting to come back, well, that would make sense. It was in January. Adhesions can be at their highest within 3 to 6 weeks from surgery, and then they can become chronic, big, strong bands right about now. So adhesions can absolutely do that. The problem is, if you had a surgery before, well, what happens if I cut your arm? You get a scar. Well, what happens if I cut you on the inside? You get a scar. That's what we call adhesions. So more surgery equals more scars, more adhesions. That's where I'm a huge proponent of laparoscopic surgery, minimally invasive, through a couple small holes. The adhesions in scar tissue are minimal. They are absolutely nominalized versus a big open surgery. So hopefully you can get a surgeon to go in there and do it laparoscopically. Now, let's say that you had a hernia repair. You got to consider maybe your hernia is back. If you had your gallbladder out and it got better, but now it's worse, well, you got to go look at that. You got to talk to your GI doctors and maybe get an ultrasound. If it was an ovarian thing, you got to ask yourself, well, did we have the right diagnosis? Was it maybe not my ovaries? It was more like diverticulitis, something like that. So, good question. I would certainly have it looked at because that's important. If it's coming back, then you got to ask yourself, did we get the right diagnosis? And if we did, and it was something like adhesions, are they coming back? Great question. Sonny, how long does it take for mesh to stop being so uncomfortable? Sonny, that's a great question. And let me actually get a plug-in for meshes. We don't use the same meshes that we used 50 years ago, right? It just makes sense. Medicine's gotten better. So those old meshes that rolled up into balls, got infected easy, broke down, they are not what we're using these days. We've gotten much, much, much better. When you see the lawyers on TV talking about, oh, you know, if you've had a problem with this, you know, this mesh, that mesh, another, call me. Typically, they're talking about another kind of surgery, bladder slings and things like that. If they are talking about abdominal wall meshes, these are ones that have already been taken off the market. So we're not using them actively. And you absolutely should ask your surgeon, what kind of mesh do you use? And you can look that up. It may not mean much to you, but it's important that the surgeon relays that to you and can tell you about it. Personally, I've done so many thousands of hernia cases that I've narrowed my mesh down. I only use 1 or 2 or 3 different kinds of meshes, and each for its own reasoning. And hopefully your surgeon has narrowed it down to 1 or 2 meshes that he uses all the time because those are good. They've proven themselves with the test of time, and it's important. Great question. The pain that you're talking about is incorporation pain. Now, that's important thought too. If you get a hernia repair, I said that if you have a hernia, that tissue is weaker than it will ever be. It'll only be, even if I repaired your natural tissue, at best 86%. What can make that better? What's going to keep your recurrence rate from 30% down to 1%, 1 to 3%? Use of mesh. So that's why mesh is important. Some people go, I don't want that mesh in me. Yes, you do. If your surgeon does it right, you want it in you. Why? If you think about it, it's almost like PVC pipe that they've cut into little strings, and then they make a mesh, literally like the screen mesh on your windows. That's important. If you look under a microscope, they have little tiny little holes, right, like a screen. Your natural tissue grows through that mesh, and we call that incorporation. Once your natural tissue goes through those holes, the mesh is then incorporated into your tissue, and now you become as strong as the mesh. And when we talk about meshes, we talk about burst strength, tear strength, these things, and they've gotten good. So now that repair, and that takes about 3 weeks to incorporate, that repair is now strong. If you get out to 6 weeks, it's really strong. In fact, after 6 weeks, I tell people, test it out. Go nuts. And if you ever get shot in your mesh. I'm kidding. It's not that strong, but it's pretty strong. All right, moving on. A couple more questions. Fran, how do you decide when to perform an open abdominal surgery versus a laparoscopic, and what is the difference in recovery time? Awesome question. Okay, so everyone who becomes a surgeon in general surgery world does their general surgery residency first. I had a great residency. I learned from some of the best. One of the things I think we could have done better is a laparoscopic portion. But here's the great part. I came up in this era where the guys teaching me were kind of the older guys who did everything open through a big incision. But the fellows that I worked with were all wanting to do this new laparoscopic thing, this new minimally invasive thing. Robots were just, even being thought of at the time. And I'm not that old, but I'm old enough to remember that. So I wanted more when I graduated from residency, and somehow I talked my wife into this, that to add another 1.5 years to my training and with getting paid peanuts, to do 2 fellowships. One I did in bariatrics, which most of you know, and I love, but 2, minimally invasive surgery. So everything you can do for general surgery, I try to do through teeny tiny holes, and that's super duper important. So for instance, this week I had a young lady who I did her gallbladder through 2 incisions that were this big, and one was that big. And that's how we did her gallbladder. You can absolutely not see any of her incisions because the one that's bigger was through her belly button and the other 2 you can't see. So you tell me, what's the difference in the recovery time? A gallbladder incision open is about that big. Laparoscopically, I just told you, it can be through tiny, teeny tiny holes. At least regularly 3 5mm and 1 10. So the recovery time is infinitely better. Just 30 years ago, 25 years ago, they were all done open and everybody stayed in the hospital. Sometimes 2 weeks. It was crazy. Not anymore. So we do these laparoscopically. It's outpatient surgery. Laparoscopy, I believe it started around 1991, has changed everything. So how do I decide? I did a minimally invasive surgery fellowship because I felt like I needed some help with that. And 2, the patients benefit immensely. I told you I had the 2 different surgeries. I was home walking my dog that night. I felt great. So if that's a testament, then that's it. Again, let me just put in this punchline. Not every surgery can be done minimally invasively. If you have a tumor, by the way, cancers are off the talk. They're off the board because from a cancer standpoint, you can get cancer anywhere in your abdomen, so that's not fair. It certainly can cause pain. It can cause obstruction. Do not ignore chronic pain. Tell somebody about it. I will tell you, screening, colonoscopies, mammograms, and pap smears are screening tests that have changed the face of medicine. Look at my face. Go get your tests done. I don't care if you're young and you don't think you should get your pap smear done. I don't need it. I'm young. Baloney. Cervical cancer used to be the #1 killer of women. A pap smear 5-minute test changed all of that. It is now way down the list. Mammograms are getting better and better and better and better. Yes, breast cancer isn't changing. The rates aren't changing. But detecting it at stage 1 disease is getting more and more and more prevalent. We are saving many, many more lives. I do tons of breast surgery. I would beg women to go get their mammograms. Starting at 40 or 10 years before anyone in their family, the youngest person in their family, was diagnosed. And lastly, colonoscopies. We are now, actually, it's a big change. It used to be 50. Now they're saying 45 or 40 if you have a family history. Get it done. You are sleeping through the exam. It's not that bad. Please get it done. Save your life. Having said that, tumors, I took one out this week. It was 12 centimeters. That's not coming through a 10mm port. So do you understand you can't do that? So no, we're not going to do that laparoscopically. Or we could start laparoscopically, but ultimately you're getting an incision, all right, because it's got to come out. So just think about that. A couple more questions and we'll wrap it up, guys. Lynette, this is a good question, actually. It's really not about Well, here's one from Melissa. My husband has a hernia and needs to be repaired, but he's stubborn like most men. He's been feeling extremely fatigued lately, and I was wondering if his hernia could be causing this. Unlikely, unless his bowel is coming through his hernia, and so he's kind of lost his appetite because food's not moving through there very well. You lose your appetite, you're just sluggish, and you're feeling miserable. Otherwise, it's probably something else. But he should get that hernia fixed, because then he can just be done with it. Lynette says, is there a brand of vitamins you recommend or prefer? What vitamins, if any, are the best for women over 45? Okay. This is something I've changed my mind on. This is actually really important. I'm not going to put any plugs in for any particular thing, because I don't like that. I try not to do that. But I can't help it by not sharing information that I've gained. This is what I do. So because I do a lot of bariatric surgery, I'm giving some people malabsorption. I am giving them a nutritional deficit on purpose. Well, how can I offset that? Well, you can have a good vitamin. Okay, so for the average Joe, the people who haven't had a gastric bypass or don't have a malabsorption or chronic issues like Crohn's disease where they have malabsorption, something like that, a Centrum, Women's One a Day, any of these things are perfect. They're absolutely fine. We should be getting all the minerals and vitamins we need through our diet, and we get the huge majority of it that way. But not all of us can say that we have the greatest diet, right? It's not the best. Plus, there is some truth that these the lands that we crop on, the lands that we grow, crops and stuff on, have been stripped of some of their minerals, right, and vitamins, and they're not replaced as usual. So they're not as rich in that stuff as they used to be. However, one vitamin every day can adapt for that loss. It's not a problem. Take your vitamins. It's important. All right, having said that, if you had a weight loss surgery, you have malabsorption, you have chronic diarrhea, things like that. Again, not a plug, but I really want to prop this vitamin up. There is a disease called cystic fibrosis, and one of the things that are associated with is severe malabsorption, right? And there is a group of people called Bariatric Advantage, that they're named after that because they came out with their vitamin for the bariatric population with malabsorption. They did some really good studies with these patients who have severe malabsorption. They use this technology called micelle technology. So when you take a regular vitamin, you're only going to get maybe 40-50% of that vitamin. Some are less, some are more, but that's the roundabout. You don't need any more than that. That's why when you pee it out, it's really bright yellow, and the majority of it leaves your body through that way or out the backside. These vitamins are really well absorbed, high up in your gut. And that's really, really important, because if you're malabsorbing or you have issues with chronic diarrhea, Crohn's disease, ulcerative colitis, these things, you need a vitamin that you absorb well, or else you're going to get dragged out, fatigued, pale, miserable, and that's a big deal. The other ones I'll put plugs in for are number one disease facing women over the age of 50, osteoporosis. Take your calcium. They come in chocolate chews now. They come in vanilla, caramel. Man, just put a bowl and put them on there. Now, they're not free. They cost about 15 to 25 calories, so don't eat 75 of them in a day. But they're important. You need to do that. That's super important. Get your DEXA scans. That's important. Having said that, one of the other top 5 diseases facing all women, because you have a period every month until you hit menopause, is iron deficiency anemia. Check your iron, get it done. An iron pill is a great idea. It can make you constipated and turn your stool a little darker, but it's normally not that bad. It keeps you from being anemic and keeps you from being tired. All right, so that is the questions. There's one from, let's do this last one. Oh yeah, this is actually from Philip, who's the one who's making me do all this, because I wouldn't have done it without him. What do you guys want to talk about? And do you want to do it in a week? Do you want to do it in 2 weeks? I'm happy to do these every couple of weeks. If you guys have a demand for more and you want certain topics, I'll rock one out every week. Short of that, thank you so much. And hi, Mom. If I don't say hi, Mom, I'm host. And yes, you guys know where I'm coming from. Do me a favor. If you like this, if you think it's educational, share it. It's important. It's free. It's yours. Just share it. And tell me what topics you want to talk about. And if there's any questions that I didn't nail on this one about abdominal pain, throw them in there. I'll see if I can get them answered this week. If I can't, I'll bring them into the next talk. All right, guys. God bless you. Stay strong. And we still live in the greatest country God's ever created. Take care.